Okay, good morning, everybody. My name is Sabi. I'm a PGY4, and I'll be giving the first emergency CCM or critical care medicine conference this year. So I'd like to thank Dr. D'Souza, Dr. Kim, Dr. Beta, Dr. Chan, and the rest of the EMCC team for helping me prepare my presentation. Can everyone hear me okay? Because I don't think this mic works. Everyone can hear me? Okay, cool.
Yeah, well, people can't hear you. I don't know.
Okay, so our case starts with a 61-year-old male whose wife called EMS because he syncopized at home. His vitals in the field: blood pressure was 86/74, heart rate was 89, respiratory rate of 20, and SpO2 was 100% on room air. He was altered, ANO ×2, pale, diaphoretic, with thready pulses. They established IV access and gave him a 500 cc bolus of normal saline and started him on a dopamine infusion. He had an improvement in his blood pressure and mental status, and they brought him over to CCT. On arrival to CCT, this was his initial assessment. So airway was intact. He had clear bilateral breath sounds. He appeared cool, clammy, and pale, but he was ANO ×3 on arrival. His vital signs in CCT are listed here. His heart rate was 151. Blood pressure was 131/96. Respiratory rate of 20. He was afebrile. And SpO2 was 74% on room air. But the nursing note said it was a really poor waveform, and he was very cool and clammy when they got the pulse ox. And his finger stick was 167. All right. So what is our preliminary problem list? Anyone want to shout out some problems that we have to address so far in this patient? Good. Hypotension, I heard. Hypoxia. Good. Good. And his symptoms: syncope, altered mental status. Good. All right. And what initial interventions do you want at this point? I like it. Good. All right. Yeah, that's basically kind of what they did. They put him on a monitor. They got him IV access. They got an EKG. And because he was normotensive on arrival, they discontinued a dopamine infusion. So for his HPI, he was a 61-year-old male who came in with syncope, but is now also complaining of chest pain. So in the field, he initially denied chest pain, but now he does have chest pain, and it's progressively getting worse since coming to the ED. He had syncopized 4 times this month already. Otherwise, his review of systems was negative. His past medical history is notable for hypertension, asthma, and polysubstance use disorder, but it was unclear if he had recently used any drugs. And his home meds are listed here. He's on albuterol, amlodipine, benazepril, and gabapentin, and no known drug allergies. So for his exam, he was diaphoretic and in distress. His cardiopulmonary exam, he had clear breath sounds bilaterally. He was tachycardic with no murmurs, and he had distended neck veins. Abdomen was soft, non-tender, non-distended. Extremities were notable for mild pretibial edema bilaterally and some hyperpigmentation, and he was very cool and clammy. His neuro exam, he was at this point ANO ×3, moving all his extremities. And this is his EKG. This is the initial EKG on arrival. So we can start with the rate. What do you guys think of the rate? Fast, I agree. How fast do you guys think? Ballpark? Yeah, 150 about. So rate is fast. Rhythm, do we see any P waves? I'm hearing some yeses and nos. Yeah, I looked at this for a while, and I talked to one of our attendings as well. And so actually this read was sinus tachycardia, but there aren't really any clear P waves. I initially thought maybe these are P waves in V2, I'm pointing there. But when you look at lead 2 below, they don't really correspond to any actual P waves. So it doesn't seem like it's sinus. So is it wide or narrow complex? Narrow. Good. So you've got narrow complex tachycardia without P waves. What do you guys think it could be? some kind of SVT maybe, like maybe an AV NRT. Our EKG gurus over here. Yes, maybe. Yeah. They said all the answers. I figured. All right. So now our patient. What like general hemodynamic state is he in? What does he have? He's in shock. Good. So there's a couple different forms of shock, right? I left out distributive because his presentation isn't really consistent with that, right? He's not like septic appearing, his cool extremities doesn't really fit that picture. So hypovolemic shock, he doesn't appear to be bleeding from anywhere, and there's no reason to believe that he's like very dehydrated, so that seems less likely. A cardiogenic shock, these are some etiologies listed here: malignant dysrhythmia, occlusion MI, cardiomyopathy, or acute aortic syndrome, and then obstructive shock. So cardiac tamponade, PE, tension pneumothorax. Okay, so now during the interview, at this point, the patient actually became diaphoretic and altered, and his repeat vital signs were notable for hypotension to 60s over 40s, and he was tachycardic on the monitor with actually a normal SpO2. So they were able to get a normal SpO2 at this point. So they bolused a liter of fluids, and they started him on a dobutamine infusion. Okay, now at this point, what bedside test do we want to do to evaluate for undifferentiated hypotension? POCUS, Sano, I heard. Okay, good, nice. Which test? Which like what's it called? Rush exam. Yep. Okay, cool. So rush exam stands for rapid ultrasound for shock and hypotension. And I like to use this mnemonic. I don't know if you guys like use it just to remember like the components. So it's HiMAP, heart, IVC, Morrison's, and like the rest of the FAST, aorta, and pulmonary to evaluate for a pneumothorax. So they do a rush exam. And this is what the patient's ultrasound looked like. Shout out what you see. Plethoric IVC, good, I agree. There's like minimal respiratory variation there. RV diastolic collapse, good, which is a sign of tamponade, good. So what is the most likely form of shock this patient has based on obstructive shock? Good. So this helps us narrow our differential. So we talked about like some of the causes of obstructive shock. PE seems like less likely at this point. The chances he would have both of these things going on are pretty unlikely. And the rest of the rush exam was negative, so he doesn't have a tension pneumo. And then these are just some causes of cardiac tamponade. So pericarditis, caused by autoimmune disease, malignancy, uremia, infection, MI, aortic dissection, mixed edema, or radiation if you had a history of that. Okay, so at this point, the decision was made by the ED to perform a pericardiocentesis. So they used an ultrasound guided approach, and they actually did the peristernal approach, and they introduced a needle into the pericardial space. So about 2 cc's of fluid was aspirated that appeared bloody. And these were his repeat vitals: heart rate 92, and systolic blood pressure improved to 110. So unfortunately, there's like not like actual vital signs documented like throughout. I guess this was like a very acute case, so we don't have like all the vitals, but this was what was in the notes. And this is the repeat EKG after that. I think there was. I can go back. You said the
swinging heart. It's not like a giant effusion that the heart's going to be swinging back and forth. Yeah.
It only takes like a small amount in a dissection to actually, to cause. Okay, this is a repeat EKG. So what's different now? What can we see? CVP waves, yeah, good. And the rates come down, right? So looks sinus. Besides the second beat coming a little early, it looks like pretty regular. So this is just and the PR looks a little long, so it looks like first degree AV block. Okay, what other tests do you guys want at this point? All we did so far was EKG and bedside sono. So some imaging, what do we offer before imaging? Labs, maybe? Yeah. What kind of labs do you guys want? Was that? TFTs? Oh, I don't think they got those, but that would be a good one. Rainbow, everything. Okay, cool. Type yes, pre-op labs, good. All right, they got a chest X-ray. They just did a pericardiocentesis. Let's make sure they didn't cause a pneumothorax. And they got cardiology and surgery consults. Yes, that's a good idea. We're getting there. Okay, so this was the VBG, the initial blood gas. Lactate's high, yes. PO2 is 16. I'm not really sure why. He actually had a good waveform, good sat after the initial. Yeah, so yeah, not as reliable, right? Yeah, that's what I thought. Okay, he had an AKI, his creatinine was 1.1 from 0.6 previously, but otherwise the rest of his labs really don't look too bad. His CBC looks okay, mild anemia, MAG's low, TROPE's negative, and his UTOX is negative. This is chest X-ray. So it's a portable chest X-ray. We don't see a pneumo, so good job on the pericardiocentesis. And it's a portable, so you can't like make an assessment of the heart size really that accurately, but even for a portable, I'd say maybe it looks a little bit enlarged. And there's some blunting of the costophrenic angle on the left, so there's like a small pleural effusion there. Okay, so cardiology was consulted and surgery was consulted, like we said. They start getting back to us. Cardiology says consult surgery because he needs a window. And surgery says, okay, let's admit this patient to the ICU. So the ED decided to get a CTA after admitting the patient to SICU because they couldn't identify any immediate cause for the effusion. He had no other like reason to have pericardial effusion. So of note at this point, like there were a lot of delays in getting the CT because nursing didn't want the patient to go to CT until he had a bed in SICU. So that kind of like complicated the whole process. I mean, they wanted to go straight up in one trip. So that caused a delay, but he eventually got the CAT scan, thankfully. And this is what it, okay. Yeah. Okay. I gave it away. I'm so mad. I'm so mad I gave it away. Okay, so you guys all see what's going on here. What's up? Kings. This is a Kings County, the CCT. So. Oh yeah, yep. That's the one. All right, so they wrote this as a type A dissection with mediastinal hematoma, hemorrhagic pericardial effusion, left-sided pleural effusion, with extension of the dissection into the abdominal aorta and a flap extending into the left renal artery. So like OMG, right? This is the new problem list. Obstructive shock secondary to type A dissection complicated by hemopericardium and tamponade. So change of plans, the SICU admission was reversed. And basically they stopped the dobutamine at this point, right? They started esmolol infusion. At this point, though, when he got back from CAT scan, his vitals looked like this. Heart rate was in the 150s. He was hypotensive to 70s over 40s. So the esmolol was titrated more aggressively to a heart rate of 100, and that improved his blood pressure slightly to 80s, 90s systolic. Plan was made to transfer him to an outside hospital. Get this guy out of here. Okay. However, the outside hospital surgeon did not want to accept the patient for transfer unless a pericardial drain was placed by the ED. So that's exactly what they did. They gave the patient some fentanyl for pain, and again, using ultrasound guidance and the peristernal approach, they placed a pericardial drain. So basically, it's the same as a pericardiocentesis, but they left a central venous catheter in the pericardium to act. What's that? We did that? We did. Wow. Like literally a central line? Literally like a central line. Literally a central line, yeah. They actually used the triple and they blocked off. Probably. I think it was just like real quick that they did it, yeah. You can use, that's true. Yep, and you can use a pigtail catheter as well if you need to.
The important thing is that once you see blood coming back from your pericardial, then that should, I think that's immediately you have to think about is gonna be placing a drain that immediately, because the immediate thing you worry about is infection, is bleeding, and is the second I take the fluid out and take my needle out, the fluid gonna really
Exactly.
cause the same problem.
Exactly. Yep, that's correct. So actually talking to so they aspirated about 20 cc's of blood, they left the drain in, and I talked to the attending who was there for the pericardiocentesis, and they noted how like remarkable it was. Like the patient's condition improved so quickly, like his mental status improved immediately upon aspiration. So these were his repeat vitals. Heart rate was 80, systolic blood pressure of 110. And then just to summarize his course in the ED, basically he syncopized and was hypotensive in the field. Rush exam showed tamponade. He had the first pericardiocentesis, got the CTA, which showed the dissection, started on esmolol infusion, but was still hypotensive and had a pericardial drain placed, ultimately was transferred to outside hospital for a CT surgery. So our final diagnosis for this case was a type A aortic dissection with hemopericardium and cardiac tamponade. Whoa, right?
You have follow-up of what?
Yes,
happened?
we're gonna get to that at the end. Good. Okay, so this is the outline for the talk. We're just gonna talk a little bit about the pathophys of aortic dissection, pharmacologic management, and like the goals of resuscitation and what the hemodynamic parameters are. Evidence for pericardiocentesis in type A dissection, and we'll go through the procedure itself briefly, and then hopefully some time for Q&A. All right, so the aortic wall has 3 layers, as we know. Inner to outer is intima, media, and adventitia. So if there's a tear in the intima, it introduces hemorrhage within the wall, which divides the intima from the media, which creates like a true and false lumen, as we know. This is an image of what it looks like when someone dissects up the aortic wall and arch into the pericardium, as happened in this patient. And here you can actually see it extend into the aortic valve, which is why aortic regurgitation is also a frequent consequence of type A dissection. And then in terms of how we classify briefly, we know about the DeBakey and Stanford classification systems. We usually use Stanford because it's just more simple to understand, but DeBakey is just like a little bit more specific to exactly which parts of the aorta are involved. So type 1 involves the ascending and descending aorta, as in our patient. Type 2 is just ascending, and type 3 is just descending. And then Stanford basically is concerned with whether or not the ascending aorta is involved. So any type of dissection that involves the ascending aorta, regardless of whether or not the descending aorta is involved, is a type A. So I just remember type A for ascending. And then type B is exclusively descending. Okay, so stay with me, guys. I know this looks bad. It's not that bad, I promise. So I'm reviewing this because it's important in order to understand like how we manage these patients and what the objectives of pharmacologic management are. So dP over dt is the rate of rise in pressure over time. And the shear force in the aorta is determined by the dP over dt. So back in 1970, this concept was studied first using an artificial model of the aorta. So they basically created like a fake aorta, and they created these intimal tears. And they subjected one aorta to pulsatile flow and then one to non-pulsatile flow. And they found that with the aorta that was subjected to a non-pulsatile flow, they could achieve really high pressures at like up to 400 millimeters mercury before a dissection happened. But for the one that was subjected to pulsatile flow, it only made it to about 120 before there was a dissection. And so this was redemonstrated with dog aortas, and basically they concluded that dP over dt is very important in the propagation of dissection. So how does this apply to real life? So the image on the right shows us a plot of like pressure versus time. In red is a normal aortic pressure tracing. So this mouse works. This is what it looks like normally. And then in purple is the effect of giving a vasodilator. So for example, if you give nitroprusside or nitroglycerin, this would be effect of that. And in green here is the dP over dt. So that would correspond to the slope of this line. And as we can see, if we give a vasodilator in isolation, the overall pressure comes down. but the slope, or dP over dt, becomes more vertical or increases, which corresponds to shear force. So essentially, if you give a vasodilator in isolation, the shear force in the aorta goes up. On the right, you can see the effect of giving beta blockers. So same thing, you have a normal aortic pressure tracing, and then in blue is the effect of giving a beta blocker. So the dP over dt, again, is demonstrated as a slope. And so if you give a beta blocker, the pressure comes down, but the slope also flattens out and decreases, which corresponds to a reduction in the shear force in the aorta. And so this basically illustrates like the physiology of why it's important to beta block or rate control patients in dissection before you give a vasodilator. And that's because you want to prevent reflex tachycardia and minimize the amount of shear stress on the aorta. Okay. So this brings us to the topic of like our pharmacologic management. So what are our targets for heart rate and blood pressure? So basically our major society guidelines like AHA and European Society of Cardiology recommend these guidelines for acute aortic dissection or targets basically heart rate less than 60 and a systolic blood pressure of 100 to 120. So there really isn't any very robust evidence supporting these parameters, but physiologically it makes sense, and that's why it remains in the major society guidelines. It actually, like these targets stem from all the way back in 1965, this paper by Dr. Wheat. They basically extrapolated data from animal studies, and poultry farmers noticed that certain flocks of turkeys were dying and found that they were dying from naturally occurring dissecting aneurysms of the aorta. And so it was found that by the addition of a really old drug called reserpine, it reduces, at low doses, reduces heart rate mainly, and not so much blood pressure. It reduced the incidence of death in these turkeys dramatically. And so they basically said, let's apply this data to humans and see what happens. And so they had like 6 patients admitted to their ICU, and they found by giving them similar drugs, reducing the heart rate and blood pressure, they were able to survive without surgery in the acute phase. And so this is essentially like where these kind of targets came from. And so as we discussed, we want to decrease dP over dt or shear stress. And so rate control should happen before administration of a vasodilator, as we said, to prevent rebound tachycardia. And so our options are between beta blockers and calcium channel blockers. So our preferred agent is going to be something that's rapidly titratable, and esmolol is a good choice in the absence of significant contraindications. It's actually considered first line. And the way you give it is a bolus first of 500 mics per kilogram, and you follow it up with an infusion that needs to be titrated about every 4 minutes until you reach your goal heart rate. So you should probably be at the bedside while this is happening. Another choice is labetalol. You can give it as a bolus and also an infusion afterwards, but it has a much longer half-life than esmolol, so it's not as preferred. It's about 5.5 hours compared to 9 minutes. And then metoprolol is another beta blocker, but the drawback here is that you're just going to give IV pushes. You can't really give it, you can't really start the patient on an infusion. So another option is a diltiazem. If for whatever reason you can't give a beta blocker, you can give this. It's actually the same dose as what we do for AFib RVR. So 0.25 mg per kg IV for the bolus at least, and then you start the infusion thereafter. So if you give a rate control agent, but your blood pressure is still not within 100 to 120, then you have to add on a second drug. So you can start with something like nicardipine. It's very useful. It has very predictable effects on blood pressure, but it has a really long half-life. This one, you just start an infusion. You don't need a bolus initially. And then another option is clofidipine, which I don't believe we actually have here. It's pretty.
In Europe, they have it, but not here in the States.
Yeah, I mean, from what I've read, it seems like a great drug. It has all the pros of nicardipine, but a much shorter half-life of about 1 minute. And it's very easy to titrate. So it's another option to consider if you work in Europe, I guess. And then vasodilators. So these are some options that we have. They seem to have fallen out of favor. Nitroprusside, at least I remember learning like nitroprusside and it causes unpredictable hypotension and potentially a rebound tachycardia, and also there's concern for cyanide toxicity, so it's not usually preferred. Nitroglycerin and hydralazine you can consider as well, but also have unpredictable pharmacodynamics. Okay, and the last bit about meds, basically, this is a very painful condition, as we know, and pain's not going to help your patient's heart rate and blood pressure. So make sure you give them something for pain. The AHA recommends IV opioids. So fentanyl is a good choice. It's short acting. You can also consider morphine or Dilaudid. So since that initial paper, there really weren't many published to evaluate the targets, like the target heart rate or blood pressure. This is one study that looked at type B dissection. Basically, they looked at patients, they separated them into two groups, heart rate less than 60, and then a heart rate between 60 and 80, and they found a reduction in aortic events for the patients who had a heart rate less than 60. Okay, so now, what is the evidence for performing a pericardiocentesis in patients who have type A dissection with tamponade? Like some of us may have learned that dissection is a relative contraindication or even absolute contraindication to pericardiocentesis. But what does the literature have to say? So the thought that pericardiocentesis could be harmful in these patients was actually based on this study in 1994, which included about 10 patients who had type A dissection with tamponade, and 4 of them underwent pericardiocentesis. 3 of them died. So it doesn't sound like all that great, I guess. But then I read the paper, and 2 of the patients who died actually had normal vital signs after fluids, but got the pericardiocentesis anyway. So one could argue that maybe they didn't need it. One of the patients got nitroprusside, but there was no mention of a beta blocker given to the patient beforehand, which we learned could be harmful or like increase the shear stress. And then another thing about this paper is that really large volumes of fluid were aspirated, anywhere from 100 to 1200 cc's. So now along came this concept of something called controlled pericardial drainage for dissection. So instead of like tapping with a needle, taking the needle out, as Dr. Imus was saying, why not like leave a drain in? And that way we can finally control how much fluid is aspirated and just take off exactly what we need. I mean, leave it in case we need to take out more. This is like the largest present study that evaluated pericardial drainage in patients with tamponade from dissection. It was a retrospective cohort study that looks at about 308 patients. Basically, 49 patients did not respond to fluids in the ED and underwent controlled pericardial drainage. The average volume that needed to be aspirated was about 46 cc's, and more than half of the patients only needed 30 cc's or less aspirated in order to restore their perfusion. And there was no mortality directly related to controlled pericardial drainage. This is another paper from 2000.
What was the mortality related to just having the dissection? How many of them died?
The in-hospital mortality was around 20%. Yeah. But they weren't related to the drainage itself. It was related to other stuff, like multi-organ failure or like rupture of the aorta post-op, stuff like that. Okay, this is another paper from 2012 and also a retrospective study, 175 patients. 18 of them did not respond to fluids and underwent controlled pericardial drainage in the ED. And this paper does a nice job of describing the procedure. They put an 8 French pigtail catheter in, and they only remove around 5 or 10 cc's at a time. And they closely watch the blood pressure, and the goal systolic blood pressure was about 90. And all of the patients underwent successful operative repair. Another study, this is smaller, but it's at a place without cardiothoracic surgery like us. So I thought it'd be relevant to include. So there are 21 patients in the study, and 6 patients did not respond to fluids and got a pericardial drain. 5 of them survived to operative repair. So the most recent AHA guidelines acknowledge that type A dissection is a surgical emergency. But if the patient's hypotensive and otherwise can't survive until surgery, then a pericardiocentesis can be performed by withdrawing just enough fluid to restore perfusion. Okay, so what is the best approach for pericardiocentesis? What's that? No, okay. There's not really any evidence that or not any high quality evidence, I should say, that gives us an answer to this question, unfortunately. So it comes down to where the biggest fluid pocket is, your patient's anatomy, whether or not compressions are taking place, and operator experience and preference. ACLS manual actually prefers peristernal approach, as I think most people do at this point. ACEP prefers peristernal and apical to subxiphoid. ATLS surprisingly has a preference for subxiphoid. This is the only paper I could find that attempted to answer this question. What the authors basically did was a retrospective review of echoes with pericardial effusions at their institution. And then they just reviewed the images for quality, distance of the effusion from the skin, and they predicted complications based on what the image looked like. So there was no actual patients who got the procedure and documented complication rates, unfortunately. But they found that the greatest distance from skin to effusion was in subxiphoid, and it was similar for peristernal and apical. And the predicted complication rate was lowest for peristernal approach at about 20%. And then apical was about 30%, and then subxiphoid was about 79%. Okay, so going back to our echo from before, I'm just going to briefly review how to assess for tamponade on echo. Someone mentioned, I think Felipe, that the RV wall was collapsing during diastole. This is a sign of tamponade. So here you can see it, but sometimes the heart's beating so fast that you actually can't tell from the single clip of the echo. So you have to do another test. So the ultrasound machine has an MO button that you click, and you place the cursor over the mitral valve, the septum, and the pericardial effusion, and the RV wall. And then you press it again, and it generates a tracing that looks like this. And this top line corresponds to the RV wall, and this line here corresponds to the mitral valve leaflet. And just to zoom in, what we're looking to see is where diastole is happening. So when the mitral valve is open, that's diastole, right? This is the E and A wave. And then this segment here is systole. And we want to know, we're interested in, is what the RV wall is doing during diastole. So if the RV wall is collapsing, as in here, during the segment of diastole, that's concerning for tamponade. The sensitivity is not that high. It's about 60% or so. It's got good specificity, about 75 to 90%. And then the earliest echographic sign for tamponade, does anyone know what it is actually?
Right.
Yeah, right atrial collapse, good. So this is not as easy to assess on ultrasound. You have to get a good apical foreview, and there's no actual M-mode test or anything like that that you can do. You just kind of have to see it happening. All right, and then we'll briefly go through the procedure itself. So peristernal, subxiphoid, apical are the main approaches. This is a picture of what the peristernal approach looks like. Basically, you get your peristernal long axis view. Something to know is that if you're doing this procedure, even though you're using the cardiac probe to visualize the effusion, that's not the probe you use to do the procedure. You should ideally be using a curvilinear or a linear probe. And that's because you want something higher frequency to help you visualize your needle. Advantages for peristernal. Again, I think this is the more preferred, just talking to attendings who have done it before. And from what I've read, it seems like this is kind of the more preferred approach if all things are equal. Advantages are it's a really short distance from skin to effusion, and you can see the needle really well in plane. Disadvantages would be risk of a pneumothorax or internal thoracic artery puncture. However, you can assess for those things using your POCUS. So you take the linear probe and you identify the mammary artery so that you can avoid hitting it when you enter the pericardium. And so they've just marked it off, but you can just kind of take a look and see where it is. And at the same time, you can look to see if the pleura is in the way. And that way you've avoided both a pneumothorax and internal mammary artery puncture. This is the apical approach. Advantages are a short path to the pericardium. Disadvantages, again, risk of pneumothorax, but also LV puncture. This is an image of what it looks like once the drain is left in place. And this is a clip from POCUS Atlas of what it looks like doing the actual procedure with the linear probe. And then finally, subxiphoid. So I think before ultrasound, this was like the preferred method, but now that we have ultrasound, it's kind of fallen out of favor as the preferred method, and there's a couple of reasons for this. It's not easy to see your needle when you're doing this because you can't really get an in-plane view of your needle. And also you have a risk of liver laceration. More often than not, you'll go through the liver itself. And there's also concern of entering the peritoneal cavity if your angle is too steep. Advantages would be it's a lower risk of a pneumothorax. There's this phenomenon known as pericardial decompression syndrome. It's something that's described in patients who receive a pericardiocentesis, but paradoxically develop like worsening hemodynamics as a result of the pericardiocentesis. This is something that's more commonly seen in patients with chronic and large effusions. So may not be so relevant to the dissecting patient, the very rare dissecting patient who has tamponade. But the authors suggested the theory for this, which is basically, we know that tamponade causes the fluid in the pericardial space to compress the right heart chambers, right? So now if you take the fluid off too quickly, you can have a sudden expansion of the RV and cause bowing into the LV, which can reduce cardiac output and cause hypotension and pulmonary edema. So the authors basically suggested that one way to mitigate this risk is to only aspirate the minimal of volume necessary to restore the patient's perfusion. And then finally, just going back to dissection, is there any indication to transfuse these patients in the ER? So this actually came up in this case because the initial team ordered a blood transfusion for the patient, but the second team canceled it. Based on what I've read, there's really no evidence for its use in the preoperative management or resuscitation of these patients. All the evidence that exists for transfusing patients with dissection are in the intra-op and post-op setting. So there was a paper that I read that it was an observational study in patients who had post-op dissection. Basically, if they got MTP, they had increased all-cause mortality. All right, so back to our patient. He was able to get to the outside hospital and emergently taken to the OR. He had operative repair of his dissection with a hemoshield, intraoperatively received blood transfusion, got transferred to the CTICU on an epi drip. He was bleeding from his intra-op chest tubes, so they transfused him again and gave him Lasix. Eventually got extubated, but then developed post-op delirium and was put on Precedex. Eventually got discharged home. And in the outpatient setting, there was one clinic note that he got followed up, basically had some sternal wound dehiscence, but otherwise was doing fine. So in summary, we, just for dissection in general, patients who are acutely dissecting the ED, remember to control their heart rate before controlling their blood pressure to minimize the shear force in the aorta. And then remember the targets, heart rate less than 60, and then blood pressure 100 to 120. If you forget about all the meds we talked about, just remember esmolol and nicardipine. Those pretty much apply to most patients. And then for the rare patient who has dissection with tamponade, if they are unresponsive to fluids, a pericardial drain can be life-saving for these patients. So it's something you should consider, and only take off what you need to restore their blood pressure and hemodynamics. These are my references. Thank you.